Hi, it's Emily. So I do not have a person with me, but I'm making it work. The pillow pet up there is going to be the head. The blanket's going to be the abdomen. The Clorox containers are going to be the arms. And then these two yoga mats are going to be the legs. So let's get started with our patient assessment. So the first part is the scene size up. So I'm going to ask, is the scene safe for me and for my partner to go on? If it is safe, we will approach. How many patients are we dealing with? We're dealing with one patient here. Are there any bystanders? Granted that this is not a real person, looks like no bystanders around. What else can we talk about? And what's the climate like? Is it still a dangerous situation? And it looks like the scene is safe. Okay, so what's the general impression? General impression is that the patient is unresponsive and shows no visible contusions, abrasions, etc., but is unresponsive and was found on the side of the road. So general impression is pretty negative. So I'm going to approach the patient and hello, sir. And I'm going to check when there's no verbal stimuli. I'm going to check a pain stimuli by pinching around the neck area, or another option is against the chest, like that. If the patient is still not responsive, I'm going to go on and check for the A, B, C, and D, so airway. I'm going to listen for breaths for 5 seconds. And I'm going to look for rate, rhythm, and quality. I'm going to make sure that the airway is open. That's number one and most important. And that also it's not shallow breathing, and that the chest rises and falls evenly. Another thing I can do is check for their carotid pulse, which is on the neck up here, and one of their distal pulses, which could be on the wrist of the patient. Next, I will look at their skin, at the texture, color, and temperature. I want it to be pink, warm, and dry to show proper circulation, as well, not pale, cool, and clammy. I want to look at any disabilities or deformities and what they're exposed to or not. And I want to try to maximize exposure by taking off as much clothing as possible while still respecting their modesty. I want to check for any severe bleeding, so I will have gloves on. I can make it do with gloves. Let's see here. These will have to do for gloves for now. And these will be put on as soon as I get to the scene. If I had real gloves, that's what I would do, but we're going to use fleece gloves for now, which is not advisable. Okay, so I'm going to pat down the patient, looking at my gloves each time to check for bleeding in each of the extremities. And it looks like no obvious extremities. So if there was a bystander witness around, I would look for medical history. So a sample, signs and symptoms, allergies, medications, pertinent medical history, last oral intake, and events that have led up to this. So now I'm going to look at the priority, like whether I want to transport this person or not. And I would definitely dispatch ALS immediately because this patient is not responsive. I'm then going to go on to do my 90-second survey. So I'm going to start from the head and feel around. Meanwhile, I want to be holding C-spine throughout this. My partner should be holding C-spine as I'm doing this check, because we don't know the mechanism of the injury, so therefore we don't know if the spine is stable or not. So while he's holding C-spine, I'm going to feel around the head, feel the back of the head for any bleeding, and look for any contusions, anything like that. I'm then going to move on to the neck, look for JBD, anything like that. move into the chest area. I'm going to pat that down, the 4 quadrants of the chest. And I'm going to hold my hands near the diaphragm to make sure that there's even chest rise and falls. And I'm going to use a stethoscope to listen for lung sounds in the 4 quadrants, so up here and here and to the sides of each. And then I'm going to palpate the 4 quadrants of the abdomen, looking for rigidity, which would be a sign for internal bleeding. I would then feel around the chest area, making sure no ribs are out of place, feeling that there. I would also be looking for contusions, any bruises to show internal bleeding, etc. I would then go on to the pelvis, making sure it's an upward motion, not downwards, and feeling for any injuries there. I would then, my partner and I, and then I would move on to the legs, patting them down, again looking for the same contusions, fractures, anything like that. I would go to the feet and I would feel the pedal pulse, and then I would also take the feet and push against them. If they are awake, I would have them push their feet against my hands and do the same on the other leg. With the arms, I would pat down the extremities and feel the radial pulse like I did earlier, and as well have them squeeze my hand if they were responsive, and do that on both arms. Then I'll have my patient and while someone is holding C-spine, then I'll have a patient near the shoulder and the lower abdomen, and I will overlap the arm and be down here, and on the count of the person holding C-spine, we'll roll the patient over so that we can see their back, and we'll pat down to check for any bleeding and to feel their spine to feel anything out of alignment on their vertebral column. And then we'll roll the patient back down. As we go ahead, if there's something that we see that needs immediate attention, we want to get a sign of, but first we want to get vitals in. So vitals will do, a pulse ox, the SpO2, we want it to be above 95. If not, we should administer oxygen. We want to take pulse, usually at the radial pulse, and at the same time we can count rest rate, which is we can count for 15 seconds then multiply by 4, and usually it's good to do that while they're doing the pulse, so they if they are responsive, then they don't know that you're counting their breaths and they won't change their breaths, so we want them to be 12 to 20 breaths per minute, and for heart rate, 60 to 100 beats per minute. This is for an adult. And these will be higher for infants and toddlers and school-age children. I want to check blood pressure with the sphygmomanometer and the stethoscope, making sure the cuff is not too small, or else I'll have too high systolic and diastolic pressure. So I will put it around the elbow of the patient and have the arrows pointing near the vein in the crevice of the elbow. My roommate just walked in. We're doing a patient assessment right now. So I will pump up the cuff, and I will pump up the cuff to a certain pressure, usually 30 millimeters of mercury above what their systolic pressure is, and then I will release it and record these vitals. If they are critical, I will repeat these vitals after 5 minutes, and then I will give the report to the ALS that is responding, giving age, sex, gender, and anything that we find in a rapid trauma assessment.